So our first speaker is Arpita Bose. So I'll hand back to her to talk about narrative production in bilinguals with aphasia and with Alzheimer's disease. So back to you, Arpita.
Okay, I have lost my mouse now. Sorry. Yes. Okay. Thank you all for your attention. And this work is a collaborative effort with my colleagues in India, Niladri, Aparna, Ranita, and students here in Reading, Abhijeet and Yesi. This work we started several years ago, and what I present is the data from some individuals with aphasia and some with Alzheimer's disease. Now, what was the impetus of this work? This work started with my observation that there are a lot of research in bilingualism as such, but also bilingualism and disease. Let's share my video. But there are limited research on the impact of disease on bilingualism. So when you have dementia, how the two languages actually deteriorate or how the two languages are affected, we don't know much about that. It's relatively less, and the situation is much dire in non-European languages. So I thought it is important that we start to document the nature of this linguistic impairment in bilingual speakers, because as we know that linguistic impairments have been used as the marker or identifying marker for several diseases. For example, agrammatism is a linguistic marker for non-fluent PPA. And we know a lot about how English agrammatism might look, but we don't know these features in different languages, such as, South Asian languages. In our case, it's Bengali. So it is important for, identifying impairments and diagnosis, and later on for rehabilitations, to start looking and documenting these impairments across world languages. I was also interested in the, theoretically, from the understanding the impact of shared languages between, shared structures between two languages and its interaction with cognition. So are shared structure better preserved? So for example, languages which have a lot of cognates, are cognates better preserved because of after aphasia or after dementia? And what are the implications for that, for treatment or for relearning? So if cognates are better preserved, shall we all try to train cognates when those are lost versus other words? So there are huge implications for understanding the impairments and how it manifests itself in different languages in bilinguals. And this is a very nice illustration of the state of the literature. And this was a review by Beveridge and Back in 2011, almost 10 years now. And they reviewed a set of articles over a 10-year period before 2011. And what they show is English is spoken by approximately 5% of world population, but aphasia research, what we have aphasia research is 60% of aphasia research are from people who speak English. So we know a lot about how impairments might look in English, but we don't have much ideas of different languages. And in this case, it is Bengali. So Bengali is spoken by 3% of world population. And in that time period of 10 years they looked at, there was only one study with a Bengali aphasic. And I am determined to change that, because the world is full of wonderful languages. And I think we need to bring those languages in the literature so that, we start to understand better about the disorders and how those disorders happen in different languages. So where is Bengali spoken? Bengali is spoken in the eastern, this circular area, eastern part of India, Bangladesh. It's a national language of Bangladesh. And there are over big Bengali diaspora across Western countries. UK has a big diaspora of Bengali speakers, and worldwide in the last census, it was around 265 million speakers of Bengali worldwide, and it's the 7th most common language spoken in the world. So there is worthwhile thing to look into this language. Now, in this slide, what I have tried to do is to, because this paper is more about difference between aphasia and Alzheimer's disease, language characteristics, what I have tried to synthesize in what we know about the language characteristics, spoken language characteristics in English-speaking agrammatic and Alzheimer's disease. So what we see here at a syntactic and structural level, agrammatic aphasics are non-fluent. They produce short and fragmentary phrases, very small MLU, often oversimplified sentences, and limited number of complex structures. In Alzheimer's disease, they sometimes and do have shorter utterance, decrease in syntactic complexity, sentence fragments. And however, these syntactic difficulties are less severe than aphasia. In terms of morphological features, it is well established that agrammatic aphasic have difficulty with freestanding elements, problem with verb and noun inflection and errors, lot of errors. In terms of morphological features, there are decline in proportion of nouns with determiners in Alzheimer's disease. Initially, not much difficulty with verbs and their inflection, but that catch up, as the disease progresses. In terms of lexical level, with agrammatic aphasia, problems with closed class words, often it is a hallmark feature of agrammatic aphasia with function words. Production is more weighted, more towards content words, more noun, and they have real difficulty with verbs and its functional morphology. In contrast, Alzheimer's disease, they have high proportion of nouns, and that, high proportion of pronouns and low proportion of nouns. And that's one of the early indicators of AD. An increased proportion of verbs and limited lexical diversity. So we know very well how these features map out in English, but what happens to a language which is different from English, such as Bengali? So we try to answer some of that question in this presentation. So this is just an illustration is where Bengali and English situates themselves in this big tree, language tree. And we know, as I was saying, some data on Spanish-English bilinguals we have from impairments. We have Spanish Catalan, but hardly in these different branches, so Bengali and English. Before we progress further, I think it's useful to understand what are these different linguistic features that are relevant for this project. So what I have tried to do is provide you the difference between Bengali and English relevant for this project. There are a lot of differences, but in terms of syntax, lexicon, morphology, I will not read these out, but just highlight the main points is word order. They have two different word orders, and Bengali is also more fluid. What that means is, you can move around your constituent items. So many a times a sentence might look, it's not grammatical in English sense, but it will be grammatical in Bengali. In terms of lexicon, open class, Bengali and English both have their set of noun, verb, adjective, adverbs. But in closed class, Bengali have a smaller closed class word, smaller set of closed class word, fewer. It is because there is no auxiliary conjunction determiners or modals. And the function that are done by these classes in English are done by a morphological inflection to noun, verbs, and other open class words. So that brings us to the morphology of the language. Bengali is very rich morphologically for nominal, verbal, and pronominal inflections. And as we know, in English, it's fairly limited. So that brings us to the research question is, what are we trying to find out in this project? So what we try to do is an exploratory study to begin with, to document and characterize the language production characteristics for bilingual speakers in Bengali and English for two types of disorders. Identify the cross-linguistic patterns. So what are the similarities and differences across these domains? And identify differences across pathologies if we can. So what we did is the data collection was in Calcutta, and anybody doing work with neurological impairments and this type, they know the challenges. So we have 3 people. What I report here is 3 individuals with aphasia, 2 individuals with Alzheimer's disease. We had collected 7 people, but I could report only 2 here. And we had a group of 6 control speakers. Important to note that they were all bilinguals. They were proficient speakers of both languages before their neurological illness, and they were sequential bilinguals, and all of them were Bengali dominant, although BWA3 felt he had more equivalent dominance in terms of the background testing we did. So keep that in mind, because I think interpretation of the results will depend on how they use those languages before. And we used the experimental task of narrative task, frog, where are you? They were required to tell the story back, and we elicited the task in L1 and L2 in 2 different sessions. So this is some sample of how the output looked. This is somebody with Broca's aphasia, moderate Broca's aphasia, the one who was equivalent dominance, but you can see English, he produced, the corpus is bigger than Bengali. In Bengali, you also see intuition of English words, but just looking at it, you will see it's full with nouns, short phrases, not much of verb inflection. So these are characteristic features of somebody with non-fluent agrammatic aphasia. In contrast, this is PaO3, who is mild Alzheimer's disease, and this is not the full transcript, but it is much more. But here, if you pay attention again, he says a lot. There are nouns and verbs, there are pronouns, but the red words are in Bengali. And what I have tried to do, these are mostly discourse marker, but in few of these, I have underlined here where my cursor is now. What he says, matha to boro gondogol korche, which means when he's having the word finding difficulty, he's saying, my head is acting up quite a bit. Then he says, moddhe memory kaj korche na. Sometimes my memory is not working. Here he says, bolte parchi na, memory te asche na. So again, so you see awareness of his problem. He is aware that he cannot get the words from his memory. So this gives you a brief idea of how the corpuses looked. Now, moving on to what we did, we used these corpuses to perform what is called QPA, quantitative production analysis, which basically allows us to get to the linguistic features of these corpuses. And we used the QPA, but also added variables to capture the features of the Bengali language. And before that, because we had such few cases, it's neuropsychological research, it's often with fewer number of subjects. So what we did for our statistical analysis, we used the single subject methodology in which we compare each case with a small group of control. And it's a well-established methodology used in neuropsychological literature. So after the corpus analysis using QPA is the overview of the results. So next slide. I know this is a very busy slide. I didn't do it on purpose, but I don't want you to get overwhelmed with this. Just look at the slide. You don't try to see much. What I want you to focus on is just the gray shading. So this is people with aphasia. This is AD. And anything gray means it's significantly different from the control. Darker gray is significantly different from the control, but the values of the patients are higher. So without even doing anything, you see people with aphasia have more problem with their linguistic features across all three domains. And there are some cross-linguistic variation I have highlighted, which is normal even in control. If you remember, Bengali had lesser amount of closed class words, and you see that here, okay? So from here, I will move on to explaining the results by each of the subject group. So first is people with aphasia. So what do we see, how their features really look like? At a structural level, syntactic level, they produce fewer sentences, shorter sentences, informed sentences, and grammatically simpler sentences. Lexical features are they had more open class word, increased proportion of noun. You see darker gray, increased proportion of nouns, decreased proportion of verbs, and they didn't produce any adjective adverbs, difficulties with closed class words, and no usage of pronouns. See, across all instances, they could not produce pronouns. Morphological features in Bengali, there were difficulty in noun inflection, but verb inflection was intact. And this was quite a significant finding in my view, because verb inflection is a characteristic feature of a grammatism. So if you have a Bengali aphasic and you say, look for verb inflection problem, you will not see, because they produce inflection correctly all the time. However, they produce limited number and variety of inflections. Okay, so they might have difficulty with accessing the whole range of inflection, but whatever they're producing it correctly. And in terms of cross-linguistic comparison, first of all is, we wanted to know if a Bengali aphasic behaves similarly to English aphasic. So in terms of syntax and lexical features, they have similar features. Shorter sentences, more noun, less verb, but the real difference from English patient comes in, in their properties with the inflection. And it's important to note that, it's not that complex inflectional systems are more difficult for the patients. Here, BAW3, he was only one we have cross-linguistic data. He had difficulty with English inflection, but not with verb inflection in Bengali. So that's something important to remember.
Just under 5 minutes left.
Okay, thank you. Now moving on to the narrative features production for the AD. Again, in the syntactic level, you have shorter sentences, less well-formed and grammatically simpler sentences, and they tend to use similar construction over and over again. However, the differences of the control were not as overwhelmingly as people with aphasia across all variables. In terms of lexical features, again, it maps on with the literature very well. They have reduced number of nouns, which is the indicator of early problem with the lexical access, increased proportion of verbs for more severe participant. And unlike aphasia, no overwhelming difficulty with closed class words or pronouns. They produce a lot of pronouns, and excessive pronoun is actually again an indicator of AD, although they did not show significantly more, but they retained pronoun production. In terms of morphological features, they had difficulty with some of the noun morphology, but again, in this case, verb morphology was fairly intact. In terms of cross-linguistic comparison, there were differential impairment with L1 and L2. And if you look at this, the number of difficulties are more in L1. And that is quite interesting to think about why, even though they were Bengali dominant, they were having such more difficulty in their Bengali, more features been affected. And in the AD, there is a big distinction between mild and moderate. As the person starts to become moderate, you see more problem with PO9. So in terms of comparison of features between the two pathologies, aphasia had overwhelming difficulty in all domains of linguistic features. And crucially, verb inflection was a distinguishing feature between the two languages. In AD, number of features impairment dependent on severity. And I think severity has an effect, but in AD, it was much more prominent. Within the impairments we see are in the expected domains. Interestingly, as I said, L1 is more affected than L2. Now, what are the contribution of this work is, I think first is a first detailed linguistic analysis and documentation of Bengali-English connected speech in two neurological conditions. Impairments in both disorders are in line with the expectation of these disorders. And I think this is very reassuring that, you know, the disorders behave similarly across different languages. Specific features might be different, but if you have aphasia in Bengali, does not make you a completely different disorder. So I think that's very reassuring to know. Shared structure showed similar patterns, but where there were not shared structures, they show distinction, and there are differential impairment in AD. I think I'm almost time. In terms of implication, I think it challenges the notion that more complex morphology need not be more difficult for people with neurological impairments. And I think this provides a good framework for cross-linguistic comparison across structurally distinct and underexplored languages. And I'm not sure if you noticed, I have left my email address across several slides. So please get in touch with me if you want to discuss more about the analysis, or if you have more questions, if you don't manage to ask in the Q&A here. And in long term, this research can help, I think, to develop markers of linguistic impairments in different disorders, post-stroke aphasia, PPAs, dementia. And that's my talk. And I want to thank all our participants for the time and enthusiasm, funding agencies, and we have benefited a lot talking to several colleagues about this research. Thank you.
Thank you. Thank you very much, Arpita. So yes, if anyone's got any questions, then please do put them in the separate Q&A chat. And we've got the first question from Pui Fong Kan, sorry if I've said your name wrong, asking about the participants. So they'd like to know what kind of aphasia were the participants diagnosed with, what recovery stage were they at, what were their educational backgrounds, and how did these factors affect their performance?
So the three people with aphasia were non-fluent aphasia, and they were all three of them are Broca's aphasia. They have parallel aphasia in both languages. All of them were college educated, at least, you know, bachelor's degree, so 3 years of degree. We ensured that they were at least read, write, and speak and understand both the languages prior to stroke, and they were, I think, approximately anywhere between 12 months to 34 months post onset.
Great. I think we've got time for this other question from Janine Treffers-Dalla, asking if you could say something about the third person singular S ending on verbs in both groups of patients. This is often very difficult for L2 learners, and I wondered if this is also difficult for these patients.
Yes, indeed. The type of morphological errors that the people with aphasia made, and it was only one transcript, if you remember, were missing of the inflection. So it is also very difficult for people with aphasia.
Okay, great. There are no other questions in the chat. I'd like to ask something very quick. You mentioned that there hasn't been much research in clinical populations across different languages. I just wondered if that's something that you think is changing, and if not, what the main barriers to that are.
This is a very good question, and I hope people who are in the attendees will agree or disagree with me. It will be nice to begin a conversation. There is a lot of enthusiasm across different people, across different research groups across the world to report and report this type of client groups. I think there are a few challenges. One is the patient access. Undertaking this type of research is quite exhaustive for the patient, and for our clients, we had to test them for 5 or 6 sessions. So that's a lot of commitment to really characterize them and then the experimental work. So that is a challenge. And in some countries, I know even true in India, people are not used to participating in research as often as they could be, how we are used in Western countries. So that's one of the challenge. But I think for going in depth, I think it was important to have a right set of team to work with. I was very lucky to have access to patients via Aparna and Ranita for Alzheimer's disease. We had fantastic linguist Niladri. I don't think I could have gone in this depth without the right type of team. And in terms of publication problem, I often think is, and I notice that I know colleagues in India are doing fantastic work, but a lot of time their work don't get published in international journals. So there are issues with the writing and getting their work, or at least the writing to the level that gets started to be published in international journals. So, there are clients, there are patients, and people are interested to do this research. So I think there needs to be more concerted effort to support this type of research.